and internal medicine at UTRGV DHR in Edinburgh, Texas. I'm going to present a case titled Mesenteric Venous Thrombosis as the first manifestation in a patient with Heterozygous Prothrombin G202108 mutation. Mesenteric venous thrombosis is a rare but life-threatening form of acute mesenteric ischemia, accounting for 6 to 9% of all cases. The prothrombin G202108 gene mutation, or PTM, is the second most commonly inherited thrombophilia after factor V Leiden. Our case describes a subacute mesenteric vein thrombosis in a previously asymptomatic adult on estrogen-containing contraceptives and with no prior history of venous thromboembolism or VTE. Unfortunately, the patient was found with VTM and required extensive bowel resection due to a severe mesenteric ischemia. A 34-year-old woman with a history of Down syndrome and polycystic ovary syndrome on estrogen-containing contraceptives presented to the emergency department due to AD history of back abdominal pain associated to nausea, vomiting, and unbloated diarrhea. A physical exam demonstrated bilateral crackles in the medium and basilar regions, fixed splitting of the S2, and tenderness in the epigastric and periumbilical areas but not rebound or guarding. A CBC revealed leukocytosis and lactic acid of 1.17, while a chest X-ray and abdominal ultrasound revealed small bowel pleural effusions and ascites, respectively. Broad-spectrum antibiotics, fluid resuscitation, and pain management were initiated. On the second day of hospitalization, the patient developed acute kidney injury, worsening leukocytosis, shortness of breath with hypoxemia and tachycardia. An emergency CT angiography and abdomen CT confirmed pleural effusion and pericardial effusion, superior mesenteric vein and portal vein thrombosis with mesenteric edematous changes and genuine fluid distension, respectively. In addition, a D-dimer was found elevated. The patient was taken to the surgical room for exploratory laparotomy, and 180 centimeters of jejunum was transected due to extensive hemorrhagic necrosis. Anticoagulation was initiated with fondaparinux with a subsequent transition to an oral anticoagulant. Functional chlorine protein assay excluded protein C and S deficiency, a factor V Leiden mutation, and phospholipid syndrome. 2 weeks later, genomic testing revealed a positive heterozygous mutation for the G202108 prothrombin gene. This case illustrates the potential for severe mesenteric ischemia in the setting of a subacute presentation of mesenteric venous thrombosis. Diagnostic delays are common due to the non-specific nature of abdominal symptoms and the condition rarity. However, CT will confirm the diagnosis in 90% of cases. Even in the absence of a history of hereditary thrombophilia, venous mesenteric ischemia must be considered in the presence of abdominal pain and factors of acquired thrombophilia, such as hyperandrogenism and the use of estrogen-containing contraceptives. Furthermore, the risk of thrombosis among carriers of the prothrombin G202108 mutation can be interpreted as cumulative and dependent on temporary hypercoagulability factors. Therefore, patients with prothrombin G202108 who have not experienced a VTE should not be prescribed estrogen-containing contraceptives and should get education and counseling regarding factors that may increase VTE risk.